Right. So good evening, everyone. I'm extremely sorry for this technical glitch. So now I'm going to speak on genetics of pheochromocytoma and paraganglioma from bench to bedside. We know the pheochromocytoma arises from the adrenal gland, chromaffin tissue, whereas the paragangliomas, the sympathetic ones arise from the thoracic and abdominal paraganglias, whereas the parasympathetic ones most commonly arise from the parasympathetic. Whenever we have a PPGL, I think it's very well known it behaves like a chameleon, right? Typically with respect to its clinical manifestations. But not only that, even with respect to its location, its secretory phenotype, malignancy potential, as well as for the associated features, it also behaves like a chameleon. So what can find out the color of this chameleon? So if at all, if we have a tool to detect this color of this chameleon, it's actually the genetics. A lot of advances have happened over the last few decades where we have moved from just few clinically known syndromes associated with pheochromocytoma to several somatic mutations associated with PPGL. So if you look at the genetics of pheochromocytoma, in fact, these advances have made pheochromocytoma and paraganglioma as one of the most inheritable tumor. If you look at the prevalence of germline mutations, it's almost 40%. And if you look at the somatic mutations, in another 30% of the patients we will have. So on an overall, 70% of the PPGL patients will have underlying genetic abnormalities. So that's why PPGL is called as one of the most heritable genetic disorder which in the oncology. Right. So based on this genetics, we do divide the genes of associated with PPGL to cluster 1, cluster 2, and cluster 3. Cluster 3 involves WNT signaling, and it's predominantly somatic ones, not like germline. So typically, I'm going to limit myself to cluster 1 and cluster 2, which are the typical germline mutations. The cluster 1 genes are the ones where there is involvement of the pseudohypoxia pathway. It not only includes the von Hippel-Lindau gene and EPAS1 gene, so it also includes the other genes which are involved in energy metabolism, like succinate dehydrogenase related genes, what I'm going to refer here after as SDHX, because it includes multiple genes, including like SDH A subunit, B subunit, C subunit, D subunit, as well as SDHAF2, and also other energy metabolism pathway genes such as fumarate hydratase and malate dehydrogenase. Whereas the cluster 2 genes are the one which involve the kinase signaling pathway, typically the red gene, NF1 gene, MAX, TMM127 are the ones which involve the kinase signaling pathway. Typically, the cluster 1 associated ones present early, especially the VHL associated ones, whereas the cluster 2 related ones present a bit late. And the very remarkable difference between the PPGL associated with cluster 1 and cluster 2 is the PNMT expression, which is typically absent in the cluster 1 related PPGL. So obviously, they won't be able to form epinephrine from norepinephrine. So typically, these patients will have a normal metanephrine, whereas with isolated elevation of normetanephrine, with or without elevation of 3-methoxytyramine, which is a COMT metabolite of dopamine. Whereas cluster 2 patients will have elevated metanephrine in addition to elevated normetanephrine. In fact, like if you look at the secretory pattern in cluster 1, it is a constitutive and continuous, whereas in cluster 2, it's more of paroxysmal. And this biochemical phenotype is going to be a very useful clue in guessing or in probably and taking a clue which cluster PPGL we are dealing with. So for that, we need to have a fractionated meta-reference. Enough in one of our very early studies of PPGL, as we can see here, like we did metanephrine and normetanephrine. Normetanephrine was elevated in all pheo patients, whereas even despite being an adrenal pheo, the metanephrine was elevated only in around 19% of the patients. That's the reason where I would like to conclude that if you do only plasma-free metanephrine, It has a very low sensitivity. Why I'm discussing that? It has a reason. I usually take an opportunity to discuss this point in every few meeting. I get a chance where I could speak on this. Whenever we order plasma-free metanephrines, we typically get a report for only plasma-free metanephrine in most of the commercially available labs. And this plasma-free metanephrine alone is of no use for us because 80% of the times I'm going to miss the diagnosis. So what should we get then? What is more important for us is actually plasma-free normetanephrine. Even if you want to have both, so individually write plasma-free metanephrine and plasma-free normetanephrine so that you not only have a diagnosis of pheochromocytoma, and also whenever you have a diagnosis of pheochromocytoma, you can get to know which cluster of PPGL you're dealing with. Similarly, but it is a bit higher cost, maybe around 7 to 8K to obtain both of these things. But simple alternative could be urinary fractionated metanephrines. But again, there could be confusion. So order 24-hour urinary metanephrine and urinary normetanephrine separately, or at least understand from your lab that when you write urinary fractionated metanephrines, they're going to give both the values individually. The advantage of this is it's actually unlike the plasma-free metanephrines in India, which is commonly measured by ELISA. This is actually measured by HPLC, and in fact, at a pretty low cost of only around 2,000 to 3,000 per sample. So we know like using these parameters will help us to differentiate the clusters. Moving on, like we know like the cluster 1 is again divided into cluster 1A and 1B, where we have VHL versus SDHB or SDH related PPGL. Can we use any biochemical parameters to differentiate these? May not be as accurately as differentiating cluster 1 and cluster 2 using metanephrine and normetanephrine, but probably to some extent we could still do that. As you can see here, that the SDHB and SDHD related PPGL had an elevation of methoxytyramine in a significant proportion of patients, whereas it was not so commonly elevated in patients with VHL or other gene-related PPGL. So when using this methoxytyramine, in fact, 78% of the times they could accurately differentiate the SDH-related PPGL from VHL. So in fact, we are not talking much about this earlier, despite elevated methoxytyramine either in isolation or in malignancy. But however, in the current scenario, we do have labs which are offering methoxytyramine along with the plasma-free metanephrines, that too measured by LCMS, which is a very accurate assay. But again, cost may be a limitation, but probably it still gives a very good information about the biochemical status of Pheo, not only to differentiate VHL from SDH related ones, more so for prediction of malignancy. Right. So as I already told, we have worked for many decades on the genetics of PPGL. So, but the classical syndromes, what we had were NF1, VHL, MEN2, and the PGL syndromes. The PGL syndromes are the ones which occur because of mutations in the SDHX genes. Let's start with NF1. As all of you know, they will have a typical neurofibromas, scaphoid spots. But if you look at the behavior of pheochromocytoma, they typically present later in life, though we have seen even children presenting with pheochromocytoma in NF1. But the usual presentation is in 4th, 5th, or 6th decade, typically as a unilateral pheochromocytoma, predominantly almost always an adrenal tumor, and it is metanephrine occurring. So presentation is more like a sporadic pheo. So only thing you will have associated NF1 features. The second one, the von Hippel-Lindau syndrome, is one of the very important syndrome because it will have several associated features. And if you look at the associated features, there will be retinal angiomas, pancreatic cysts and pancreatic neuroendocrine tumors, cerebellar hemangioblastomas, even rarely endolymphatic sac tumor, and also renal cell carcinoma, typically clear cell renal carcinoma. If you look at the behavior of Pheo in VHL, they're typically bilateral adrenal, often associated with multifocality, where there is an associated abdominal sympathetic PGL, whereas parasympathetic paragangliomas are pretty rare in VHL syndrome. If you look at the MEN2A I think again very familiar to all of you. They will have a medullary thyroid carcinoma. Sometimes they may also produce ACTH and CRH. As you can see, this lady with MEN2A who presented with Cushing syndrome because of ectopic ACTH secretion from MTC. A set of patients, especially typically with those who have 634 codon mutation, may also have skin lesions called cutaneous lichen amyloidosis. They are present in a smaller proportion, but if they are present, they speak for you that you're dealing with a patient of MEN2A. Again, if you look at the PCC behavior in patients with MEN2, they're again typically adrenal, metanephrine occurring. Most often, they will be bilateral. If you look at the MEN2B, again, the associated features would be neuromas and maybe mucosal, right? As we typically come with like bumpy lips and tongue neuromas, even conjunctival neuromas. And they will have morphonoid habitus. If you look at the corneal examination, you may get some corneal now thickening. So they may also have intestinal ganglion neuromatosis. But if you look at the PCC behavior, again, as I told earlier, this is of the similar type, bilateral, adrenal, and metanephrine secreting associated with MTC. More to the fourth important syndrome, the SDHB, also called as like paraganglioma syndrome type adrenal paraganglioma, which is a very typical presentation in SDHB syndrome. But often they may also have associated multifocal disease, which could be adrenal or even head and neck paraganglioma mass. And most important feature of this is increased risk for metastasis. They're very aggressive and they will high risk of metastasis. Sometimes it may vary for up to 70%. Move on to the other paraganglioma syndrome, SDHD syndrome, also called as paraganglioma syndrome type 1. They're typically head and neck paragangliomas, though they can also have extra adrenal paragangliomas, which may be sympathetic, as well as adrenal pheochromocytoma. The most common mutation in them is because of the mass effect, typically because of the parasympathetic paragangliomas in the head and neck. So it could be a nerve palsy or a palpable mass or so on. But be sure that like whenever you are having a SDHD associated head and neck paraganglioma, they're more likely to be bilateral. They're more likely to have an associated secretory sympathetic paraganglioma. To the data of what we had in KEM, when we did the genetics for around 150 patients with PPGL, which included both familial syndromic as well as apparent sporadic, and also variable location and number of pheochromocytoma. So we did actually not clinical exome. We limited ourselves to screen for only VHL, SDHB, D, C, and RED, because this was the project planned way back in 2008 and 9. And we also did MLPA for VHL and SDH related genes to rule out large deletions. Look at the results. There was a good yield of almost 33% of the PPGL patients at our center had mutations, the most common being VHL, followed by RET and SDHB. The prevalence of mutation, as expected, was 100% in familial syndromic cases, whereas the apparently sporadic ones had only mutations in around 16%. When we have an apparently sporadic unilateral PCC, the prevalence was even lower, which was only around 11%. When we compared our data with rest of the world, it was similar, the VHL being the most common in familial syndromic, as well as in apparently sporadic, as well as bilateral PCC. Whereas in malignancy and among SPGL cohorts, SDHB was the most common. And this was actually matching with rest of the world's literature. What's really differed in India was, unlike in the rest of the world, where the unilateral PCC, the most common mutation was SDHB, it was VHL with us. Again, in multifocal, where there is a combination of PCC with SPGL, the SDHB is the most common mutation outside India, whereas with us, it is still the VHL. Based on this, we designed a targeted gene approach. Again, this may not have a great relevance in the current scenario because the availability of clinical exome sequencing has become relatively cost-effective, and most of them are choosing for next-generation sequencing over a targeted gene approach. But there are situations where we won't be able to get a genetic testing. In that scenario, definitely this will help us to know what could be the possible associated mutation. If there's a syndromic association, it's very easy. For example, if a patient with Pheo has a MTC. I know what I'm dealing with. It's meant to. If we have a patient with unilateral PCC, most likely we may have a VHL, or rarely we may have SDHB and SDHD. If you have a bilateral PCC, if that is a metanephrin occurring, I know it is meant to. If it is like non-metanephrin occurring, I know it is a VHL. If it's multifocal, it is typically VHL. If it is SPGL, most likely SDHB. If it's a malignant, though yield is less in our cohort when compared to rest of the cohorts of malignancy, the most common would be SDHB. Whereas if we have HNPGL, either as isolated or in association with other tumors, it's typically SDHD. We also had analysis for pediatric PPGL and their genetics. So they had significantly higher proportion of mutations when compared to adults. And compared to adults, there was no RET or NF1 mutation documented in our pediatric patients, whereas the VHL was the most common in both the groups, but it was much higher in children. The children had higher frequency of familial syndromic presentation, bilateral PCC, and multifocal disease. It's again going in line with the world's literature. So where VHL was the most common mutation in children, followed by SDHB and SDHD. Of course, we also had similar behavior. But however, in NIH series, the SDHB was the most common, probably because of like being a high-level referral center. They had a lot of patients of SDHB with malignancy being referred over there. Moving on to the bedside application of the genetics in PPGL, we know VHL syndrome has type 1 and type 2. Type 1 is typically truncating, where we don't see PPGL, whereas in type 2, it is non-truncating, where PPGL is more common. So again, we did analysis for a cohort of VHL. So, and in that study, we had around 31 genetically proven VHL patients. 81% had missense mutation, similar to the world literature, where 83% of VHL-associated Pheo patients had missense mutations. So typically, there is missense mutations rather than large deletions. In fact, when we analyzed our patients, the whole literature with large deletions in VHL, the prevalence of PPGL was very low, less than 5%. And in fact, most of the time, they were unilateral and they were never bilateral, unlike missense mutation patients who typically present with bilateral PCC. Again, when you go deeper into the genetics, we see the missense mutations are the more likely to have Pheo, especially those who have a missense mutation exon 3 are the ones who have the highest odds. Even if you go deeper, the one who have this C167 codon mutation, they are the ones who have highest risk of Pheochromocytoma. So we know even in VHL patients, if someone has a missense, typically exon 3, typically codon 167 mutations are the one who have highest prevalence of Pheo. Another interesting phenomenon we described in VHL patients is anticipation. It's a very interesting finding. In fact, we are the one who we described this phenomenon in VHL for the first time. Typically, though it's described in like trinucleotide repeat diseases, it has been recently described even in patients with autosomal dominant disorders. Here in this study, we had around 8 parent offsprings from 5 families. PCC was the initial presentation in all, and one of the offsprings diagnosed first, which is actually again making us strong to say about the phenomenon of anticipation, because most of the times it is argued that offsprings are diagnosed first basically because of family screening, but it's not the way in our study. In fact, in all the pairs, offspring was the one who was diagnosed first. Offsprings had lower age at presentation, higher number of PPGL, and also similar tumor size, though numerically it was in fact larger in the younger population. So it clearly says that there is a phenomenon of anticipation in VHL. Moving on to MEN2, again we have this patient who presented 22 years of age with Pheo, and to get diagnosed with MTC later on at 41 years of age. In fact, when his sons were screened, both of them had the mutation. Both of them underwent prophylactic total thyroidectomy despite calcitonin being normal. In fact, histopathology revealed a C-cell hyperplasia in both of them. So it's very, very important to have the mutation of RET in patients with MTC or Pheo, because that categorizes or stratifies the risk of both MTC as well as Pheo. Those who have an ATA highest risk mutation, that is M19 M118T have the highest risk of both MTC as well as Pheo, whereas even M2A patients, that is who have ATA high risk mutations, they also have high risk of MTC as well as Pheo, whereas the risk is lower in patients with moderate risk mutations. In those who have high or highest risk mutations, the screening for Pheo should be started, if not by 8, at least by 11 years. Of course, the thyroidectomy should be considered in the first year for those who have highest risk mutations, before 5 years for those who have high risk mutations. Right, and moving on to SDHB syndrome, again, look at this patient who presented with PGL at probably at the root of organ of Zuckerkandl at 14 years of age, treated and sent back home, but she came back after 3 years with a metastasis. So this is something which is very typical for SDHB. And then the father was screened, who also had an extra-adrenal paraganglioma. Very disheartening is that there was also another girl who died at the age of 12 years because of refractory hypertension without a diagnosis, whereas another child who is around 1.5 years of age now is also a carrier who has been closely monitored for the development of SPGL. Moving on to the SDHD syndromes, again, this patient was 38-year-old with presented with tinnitus, decreased hear, a visible mass in the left ear. There was no family history, but he was hypertensive. He had bilateral tympanic paragangliomas and also bilateral carotid body tumors. This is something which is very typical for SDHD, that is the multiple adrenal paragangliomas. In fact, this patient also had bilateral adrenal pheochromocytomas as well as another abdominal sympathetic paraganglioma. You can see this patient, wherever it is possible, he has tumors. So again, if you look at these patients, those who have truncating mutations are more likely to have high penetrance for PPGL. Again, for a non-P81L codon mutations have a higher risk for PPGL. This is another interesting thing, probably Sarathi would have already discussed, is like that there is a rapid enhancement in the arterial phase of the cluster 1 associated PPGL, which are non-metanephrine secreting, unlike the cluster 2 related ones, which are metanephrine secreting. So in fact, it can also give us a clue. So what kind of PPGL we are dealing with, whether it's a cluster 1 or cluster 2, even before we can obtain the catecholamines. Another importance of genetics is, using a precision medicine for deciding the nuclear imaging choice. As we proved way back, like that there was a cluster 1 related PPGL had a higher uptake of FDG PET, but not for MIBG, whereas there's vice versa in cluster 2, where they had a poor uptake of FDG PET, whereas they had a good MIBG uptake. So again, if you know what kind of cluster PPGL you're dealing with, either by biochemistry or by genetics, you can decide what could be the choice among FDG PET and MIBG if they're the only two imaging modalities which are available with you. Even the SUV on FDG was significantly higher in cluster 1 related PPGL compared to cluster 2. But however, we have several other nuclear imaging modalities now which have come up, like DOTA, which is commonly available even to us, and DOPA PET, though it's not very commonly available. So if we have all these available with us, so if we have an apparently sporadic Pheo, you can go for either DOTA or DOPA, both will work well. But if we have a cluster 1, we should go for DOTA PET. Whereas if we have cluster 2 and if DOPA is available, go for DOPA, but most of the time it won't be available, so we end up doing DOTA PET itself. But however, the two exceptions are the EPAS1 mutation and prolyl hydroxylase mutations, where DOTA doesn't do a good job. So probably here, the second best choice would be an FDG PET. If we don't have DOTA, even in other SDH patients, we can still go for an FDG PET, but FDG PET is not a good test for cluster 2 PPGL. Another important message we gave in our recent study, especially in children when we were doing a Deuterated PET CT, is that This could be a very useful adjunct in detection of pancreatic neuroendocrine tumors. In fact, several lesions which are missed by the anatomical imaging and as well as FDG PET were picked up by Deuterated PET-CT. Probably we were looking for this recommendation of Deuterated PET-CT being commonly used in the surveillance of VHL children. Another important implication of this genetics for the management of PO is while considering cortical sparing adrenectomy. In fact, this is an international multicentric study initiated by Newman, in which even KM was part of. So here, typically we consider cortical sparing adrenectomy for patients with bilateral pheochromocytomas. When we are dealing with patients of MEN2A, the cortical sparing adrenectomy was less successful. However, the recurrence rate was significantly lower in MEN2A patients. This is the difference which we had in the study between MEN2A and VHL. To conclude, PPGL is one of the most heritable disorder with germline mutations in almost in 1/3 of patients. And of course, it genetic depends on the age, multifocality, and metastasis. The genotype-phenotype correlation in VHL and SDH depends also on the type of mutation, which exon is involved and which codon is involved. We're going more and more precise on utilizing the genetics. And genetic test helps not only in the management of a particular patient and also in the management of family members. Thank you so much.